Good morning, and one more request. You will see that we are starting to post easel sheets. Those easel sheets have priorities that each of the panel members have identified. And we'll be asking, beginning with this panel again, for each panel member at the end of your presentation to identify 1 to 3 priorities that you see need to go forward in terms of taking action. Your participation will be, we will give you 3 colored dots. The green dot is for the absolute highest priority. So would be your number 1 vote. The yellow dot is, it's an important priority, but the green dot has to happen first. And the red dot is, it's important, but it can't happen now. So green is like the light, like the stoplight, right? Green, yellow, and red. Stop for red. So we'll give you each of those dots during the lunch break, and definitely after the third panel, please vote, because it will be your help in helping us set priorities. So thank you.
Okay, good morning. So we have heard a lot of very interesting, thoughtful points from Dr. Fermin and Dr. Perestable, and we've also heard hints to outright suggestions that even though we have a lot of data, there are some real questions about whether and how the way data are collected on Latinos in the United States actually serves to represent accurately the heterogeneous Latino-Hispanic populations, or whether indeed there may be some exclusionary consequences. And so what we're doing in today's work of the 3 panels that we're going to have is this first panel, we're going to get an overview of why and how ethics even comes in as a consideration when looking at how data are collected. Okay, that's what we're going to do in this first panel. Because we understand from what has been presented already that these are not, a lot of the categories we use are not indeed scientific. They are historically and socially constructed categories that are rooted in decades of disparities, indifference, stereotypes, exclusion, and indeed, as Dr. Perestable noted, US domination of Latin American countries. So what we want to do today is get the overview in this panel. We have 2 really superb presentations about to happen. And that will give you some sense of what are some of the ethical considerations, because this is kind of new looking at it this way. The second panel is then going to zone in looking at Latino health with an eye to understanding how some of these challenges we're talking about data either not being collected, like language or country of birth or how many years in the US, how that may be affecting our ability to indeed address health disparities. And then the third panel will be sort of, well, what are we going to do about that? And what are we going to be able to consider as our action steps from here on in? And that's where the dots and the feedback from you that Dr. Lichtveld just talked about will be coming in. So just to clarify that. So I am really delighted that today we have 2 extraordinary persons presenting to us in this opening panel, which is called what are the ways, well, I'm not saying it exactly right, but what are the ways that data has to do with health ethics and with public health ethics? And we have Dr. Carla Saenz and Dr. Ken Dominguez. I'm going to just let you know a little bit about them. Dr. Saenz is Bioethics Regional Advisor in Knowledge Management in Bioethics and Research at the Pan American Health Organization. Dr. Saenz is in charge of Regional Bioethics Program at PAHO, the World Health Organization's regional office in the Americas. She holds a PhD in philosophy from the University of Texas at Austin. And prior to joining PAHO, she served as a postdoc fellow and guest researcher at the Department of Bioethics at the Clinical Center at the National Institutes of Health, where her research focused on population-based bioethics. She also worked as a professor at the University of North Carolina at Chapel Hill. PAHO's regional program on bioethics was established in 1993 to provide technical cooperation on bioethics to the countries of the Americas. Its main areas of work are research ethics and public health ethics. It houses the PAHO Ethics Review Committee, which reviews all studies conducted with PAHO's involvement in the region. Dr. Ken Dominguez is a medical epidemiologist in the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention, and a national and indeed international expert on HIV in pregnant women, infants, children, and Latinos. He received his BA from Harvard University and an MD, MPH from Columbia, and did his residency in pediatrics and preventive medicine at Harbor-UCLA Medical Center in California and the CDC in Atlanta, where he trained as an EIS, Epidemic Intelligence Service Officer at the Puerto Rico Department of Health. In 1991, he became a commissioned officer in the U.S. Public Health Service and serves as rank of captain. He has worked in CDC as a medical epidemiologist since '93, describing the neonatal, pediatric, and adolescent HIV/AIDS epidemic, and now works in the area of biomedical interventions to prevent HIV transmission. He serves as CDC co-lead on guidelines for prevention and treatment of opportunistic infections in children and adolescents and for non-occupational HIV prophylaxis. Dr. Dominguez co-founded and is currently co-chair of CDC's Latino-Hispanic Health Work Group, a scientific work group focused on improving Hispanic health in the U.S. And he, as we will learn, recently co-authored and was the lead author of the Hispanic Health Vital Signs. So I would like to bring up Dr. Sands. Thank you so much.
Good morning. Thank you for having me here. It's a real honor to be able to address you today on public health ethics issues. So I want to, hold on, let me figure out. Okay, I want to start pointing out this book, Public Health Ethics, Cases Spanning the Globe, that it has been published, how many days ago? 3 days ago? I'm very happy to, I think it's the first time I stand in public and announce that this book has been published. My lead co-editors are here in the room, Dr. Drew Barrett and Dr. Leonard Ortman from CDC's Public Health Ethics team. So I want to start the discussion about ethics, discussing a case from this book, a case presented by Erica Blackshear. It's a case on obesity prevention in children, and since time is tight, it's going to be a very, very rushed discussion. But I think starting with a case shows us what is it that ethicists do? How do we do work on public health ethics? So there's a task force that has been convened to develop a strategy to prevent obesity in a very poor state in the US that has very high obesity rates. The population in these states suffers disproportionately from stroke and its risk factors. The poor, minorities, and children are especially at risk. So, as you can imagine, there are various public health concerns, and but there are also worries about cost, because the costs that are increasingly going up. So this task force that has been convened, imagine you are part of that task force. And the task force wants to decides that they want to use a campaign that targets children, because they say, well, we have a special duty to protect children. And you're in this task force and you find yourself in the middle of this discussion. So some people say that we should use hard-hitting messages. For example, messages portraying obese and unhappy kids, because we have the duty first to be honest about the facts, and because those messages trigger responsibility of parents who can actually induce some change, and because those messages, we've learned they work, they're effective. That's a lesson that we've learned from tobacco campaigns. Some people in the task force are, however, uncomfortable. They say that this campaign blames the victim and stigmatizes those that are suffering from obesity. They propose that instead we focus environmental barriers to healthy choices. And they say, well, we should opt for this type of campaign because the culprit in this case is unhealthy food, not the people that eat it. But then the first group says, well, but you know what? That can be as kind as you want, but it doesn't work. So we're failing on our duty to protect the health of these children. What should we do? This is a type of scenario that raises a number of ethical questions. Because you might be asking yourself, is it ethically permissible to use stigmatization as a tool to prevent disease and promote health? Is it ever acceptable to do that? In some cases, perhaps, would any degree of harm ever make it ethically acceptable? Is it ethically acceptable to use stigmatization if only to protect children? Perhaps not adults, but only children? What's the limit of our duty? We have a duty to advance the health of these children. Does that mean that we can use stigmatization for that purpose? Is it ethically acceptable or not? So I want to present, we're going to start this discussion. I think it'd be fascinating, but we don't have the time for that now. But I just want to show this discussion to you because what you will notice right away is that these questions about whether, for example, it's ethically permissible to use stigmatization to prevent disease are questions that cannot be answered with data and evidence. It's just impossible. You don't know. You can have all the numbers, all the data you want, and you will not know if it's ethically okay to do it or not. So they're ethical questions. So by definition, they cannot be answered invoking data. We might need data to produce a final answer, but data on its own will not answer the questions. What we need is ethics analysis. And the law will not give the answer either. The law provides the strictest protection that we can think of, but the law cannot and should not be used to capture all ethical concerns. It's not like that in any other area of life. It's not desirable. It's not possible. Imagine the richness of your moral life, what you ought to do to be a morally good person. It's not just dictated by the law. The way you treat your children in the morning, it's not that the law tells you how to act. The law tells you, focus on as it were, the really bad things. So it cannot possibly cover all ethical issues in public health, like it doesn't cover all ethical issues in any aspect of our lives either. Furthermore, ethics is the discipline that allows us to reflect on the law and on what the law ought to be like. So if something, after ethics reflection, if we realize something ought to be the subject of the strictest protection, then perhaps we should change the law. And we've done it in many countries, and there's still in this country too, but it'll probably take you 5 minutes to realize that there are a number of laws in a number of countries that are still very unethical. So what we need to do to answer these questions is to do good old ethics analysis. So I want to introduce to you bioethics as a discipline. I want to make very clear that bioethics is not a body of doctrine. It's not a code of rules. We should never confuse ethics with compliance. Bioethics, if anything, in all its areas, including public health ethics, is a discipline that is mostly about an activity, the activity of conducting ethics analysis on the basis of reasons, arguments. There's no such thing as an ethical algorithm that will always dictate, oh yeah, this is the right answer. There's nothing like that, and we find it uncomfortable. And I think we keep looking for that because it's extremely uncomfortable to have a discussion like in that task force. It's very, we feel at unease when we have to argue about ethics. There are ethical principles, of course, but they can dictate conflicting action in any situation related to health. Oh, principle of beneficence dictates that you act this way, and principle of respect for autonomy dictates the opposite. So what do we do? So public health ethics is one area within bioethics, broadly understood, that deals with the ethical issues that are inherent to public health. And I want to point out that there's some ethical issues that are intrinsic to public health. For example, we all talk about, oh yeah, we have to reduce inequities, but we also have to maximize health benefits for all. How do we balance them? Okay, public health ethics has come to stay in public health. The most important characteristic of public health ethics, it's its focus on population. So I think that if you think about bioethics, historically, there's been a lot of interest in research ethics. Yes, we've done really bad things in the context of research with human subjects. Then there's been a lot of interest in clinical ethics, end-of-life issues, beginning-of-life issues. Man, those really attract our attention. But public health ethics is kind of like, I say, it's like the ugly duckling. It kind of goes behind. And we haven't done as much work on this area of bioethics as we've done in clinical ethics and research ethics. So it's very common to think, to think that we can just extrapolate what we know from clinical ethics and apply it to public health ethics. But the problem that we have if we try to do that is that populations are not just many patients together. Populations have embraced a diversity of values and interests. So there's the characteristics of public health that shape public health ethics that we ought to take into account. Not just a focus of public health on populations, but also, for example, that the way you do things in public health is often using governmental action. Look, we're at CDC, governmental agency. You use public policy to advance public health. You deal with a good that is public, that is collective. Public health, there's some aspects of public health, of course. Clean air is the most obvious one. It's neither yours or mine, it's everybody's. So it's very different from my kidney versus your kidney. So additionally, public health has an intrinsic emphasis on prevention. And that puts you in an odd situation because since you want to prevent health problems, you're often dealing with statistical people. You're dealing with these numbers, and that's very different from the situation of a physician going through a decision-making process with a patient, sitting in front of him with his own values and his own kidney and So, and additionally, public health has an intrinsic orientation to results because, as I said, it's conducted by a public health authority that at the end of the day has to say, hey, I'm accountable, I received this is what I achieved. So I have this picture because what I wanted to say ultimately is that there's some things that are very, very relevant if you're dealing with individuals. But once you zoom out and see the big picture, which is public health, they become less relevant. And some other concerns become more important. So ultimately, one thing that I want to emphasize is that an analysis, I'm just trying to see how good I'm doing with time, based on individuals and individual decisions is, as a rule, an analysis that's only based on that is inappropriate for public health ethics analysis. Not only because of what I just said, that we deal with public and collective goods, and I think this is extremely important because we tend to assume as if many things, as if everything in our lives would be the result of individual actions. But some things you just didn't choose, and you cannot even renounce to them. For example, the herd immunization. The benefit that I get from everybody else getting vaccinated. So you cannot say, oh yeah, I refuse to enjoy that benefit. It's impossible. So health as a public good has a particular impact on the ethics analysis that you can conduct. Additionally, we've talked some about this, the social determinants of health. Health is to a great extent socially determined. But so where on the social economic gradient, what your gender, your race, everything, all those things impact on your health. But I didn't choose to be born a Hispanic woman. So it's not a matter of choice. It's not a matter of voluntary decision. No one decided where in the socioeconomic spectrum to be born. So we cannot act as if public health, we cannot just base our analysis on individual aspects or voluntary choice. And additionally, because we very often forget that we have a public health authority that has a mandate, that we as a society have given the public health authority the task to do certain things. For example, protect public health, prevent disease. And that public health authority is going to be accountable. You know, if there's a Zika outbreak in the US, then we'll say, okay, what did CDC do to protect us? So that's why it's so important to address public health ethical issues, taking into account the characteristics of public health, and not just merely extrapolating from clinical ethics as a framework to guide the discussions. So today we've been discussing a number of issues that I think we've been discussing the important challenges of data collection to address the health needs of minorities. But I want to point out too that the ethical problem that has to do with data collection is not that we're not doing it. You don't need to bring me as an ethicist to tell you that. We all know that there are things that we're not doing and that we're supposed to be doing. But data collection can also be the subject of analysis from an ethics perspective. And there are many questions that should be discussed with relationship to data collection that are important, and perhaps I would say are particularly more important now that we have mechanisms to collect data that we hadn't anticipated. I'm talking about big data. Is it ethically acceptable for health authorities to collect data that includes personal information? All personal information, some personal information? Does the public health authority acquire certain ethical duties by virtue of collecting data? What are exactly those duties? Do individuals have to provide informed consent for their data to be collected? For their personal data? For what? Always? Sometimes? In which cases? What data is it ethically acceptable to collect? Are there data that we would think it's not acceptable for a public health authority to collect? Does collecting data imply duties or restrictions for its use by public health authorities? Can public health authorities, for example, pass those data to other parties? To some parties? Which parties? Why? Under which circumstances? Is it ethically acceptable, or could it even be ethically mandatory for public health authorities to share data? Again, which data? So there are a number of ethical issues that can arise in relationship to data collection, and in various forms, from specific projects to research to standard surveillance work. And I think we as a rule tend to do very little reflection about that. And well, I invite you all to pursue these questions. I'm going back to the fact that the public health ethics book is out there. I think that's a great tool for training on public health ethics, and I strongly encourage you to go look at it and strengthen your skills for ethics analysis. As said before, and I just want to end quickly by telling you a couple of things about the PAHO's regional program on bioethics. We do give technical cooperation on public health ethics to the countries in Latin America and the Caribbean. Since 2012, we give priority to public health ethics, not only because we're a public health agency and it seems like the right thing to do, but because the member states of the Americas agreed on certain work on bioethics being done, and we have a resolution for the work on bioethics, and public health ethics has been prioritized. So based on that, what I try to do is I work with several technical areas within PAHO, so the work on ethics is part of the work they produce. And for example, I've been just working with my colleagues in the immunization teams because they're producing tools for the countries to develop nominal immunization registries, and there's a section on ethics of collection of the use and data, and use of data for nominal immunization registry that's going as part of PAHO's work on immunization. There are a number of other initiatives, also some of them are led at the global level. For example, with WHO, we're developing ethics guidelines for public health surveillance, and we've produced a number of other documents on, for example, balancing equity with maximization on health when setting priorities to advance universal health coverage. I invite you to go to our website. We have a public health ethics list. You can sign up for that on the right tab, and a number of tools are being disseminated. Overall, I think that because public health ethics is, as I said, kind of like the little ugly duckling among bioethics, a lot of the work we do is public health ethics training. Anyways, it's been a pleasure being with you. Thank you.
Great. First of all, I just wanted to thank the Office of Minority Health and also the Tuskegee Institute for holding today's seminar on ethics in relation to Hispanic health. And it's really a great opportunity for us also to share information about a recent Hispanic vital signs that was published last year, and some ethics-related methodological lessons learned that will highlight some of these ethical principles. So with that, move forward here. The typical disclaimers. Presentation does not represent the official position of the CDC, and I have no conflicts of interest related to this presentation other than I'm Hispanic. So in terms of acknowledgements, in terms of the vital signs that was published back in May of last year, is entitled Leading Causes of Death, Prevalence of Diseases, Risk Factors, and Use of Health Services Among Hispanics in the U.S. between 2009 and 2013. I just wanted to first acknowledge our co-authors, some of which are sitting here in the room today. Dr. Anna Pinman Aguilar, raise your hand. I'm not sure, I think Ted Castellanos is here, and Dr. Alfonso Rodriguez Laines, one of our speakers. I don't know if there are any other of our co-authors here, I don't think so, okay. Also, this is a list of all the folks a lot of the folks that participated in the analysis. It was a huge effort from the Office of Minority Health, Dr. Leandros Laberd, all the folks from the Office of Minority Health and Health Equity. I think Julio was here as well, Descent Talon-Pierre, to the Vital Signs staff, to all the statisticians from the National Center for Health Statistics. It was just an amazing show of support to provide the support needed to do this publication, and as well as some community partners. So in terms of a few introductory comments, Hispanics are estimated to represent about 1 in 6 people in 2015, and about up to 1 in 4 people by the year 2035. We're currently the largest racial ethnic minority population in the U.S. Currently, as was earlier mentioned, the Hispanic Community Health Study, also known as SOUL, is being undertaken in 4 cities across the United States, and it has shown some key differences, as we saw earlier, by Hispanic origin and other factors. However, that is information that's specific to those 4 cities, and even though they're large cities and they're cities where Hispanics live, it's not necessarily representative of the whole U.S. So that's one of the reasons why we undertook the vital signs analysis. So in terms of purposes and methods, the idea was to conduct a nationally representative study of causes of death, prevalence of disease and risk factors, and use of health services. Methods, we compared Hispanic subgroups, and non-Hispanic whites by nativity and sex where possible. We limited our analysis to 18 to 65 years of age during 2009 to 2013. And in terms of the various components of the study, sociodemographics, we looked at the American Community Survey, which is part of the census. For leading causes of death, we looked at specifically at the National Vital Statistics Systems, which is basically based on death certificates. Disease prevalence and risk factors, we looked at both the National Health Interview Survey and the National Health Examination and Nutrition Survey. And in terms of use of health services, we looked at the National Health Interview Survey. So in terms of the methods of those different studies, I think for those of you who are unfamiliar with the different studies, the American Community Survey is a yearly national survey of vital information. So it sort of fills the gap between the biennial, every 10-year census. And it helps determine how more than $400 billion in federal and state funds are distributed. And in 2014, there were 2.3 million housing units surveyed across the country, including over 165,000 actual interviews of individuals. The National Vital Statistics System provides mortality data from death certificates, and in 2013, this included more than 2.5 million deaths. The National Health Interview Survey, obviously it's a survey, includes personal household interviews regarding a broad range of health topics of nationally representative non-institutionalized populations, between 35,000 to 40,000 households and 75,000 to 100,000 individuals. And then finally, but not least, the National Health Examination and Nutrition Survey, NHANES. It's a program of studies, and it's a combination of interviews and also physical exams. So it's sort of the best of both worlds. It assesses health and nutrition status of nationally representative sample, and it includes about 5,000 persons, including adults and children. So in terms of looking at the data from the American Community Survey and the sort of demographics, here we can see that overall, when you break things down by Hispanic subgroup, you can see that Mexicans, Puerto Ricans, and Central Americans represent about 8 out of every 10 Hispanics living in the U.S. The median age, you can see that non-Hispanic whites, median age of 42.8 compared to Hispanics of 28.0. So Hispanics on average about 15 years younger than non-Hispanic whites. But when you disaggregate, you can see the big difference between Mexicans and the various rest of the groups. Mexicans were the youngest at on an average of 26.2 years of age, and the highest age was amongst Cubans at 40.6 years of age. So quite a spectrum of difference there. Percentage was less than a high school diploma. Non-Hispanic whites 8.3, Hispanic Latinos 35.3, with a high of 44.9 for Central Americans in yellow, and a low of 14.9% in the greenish blue color at the very bottom for South Americans. So Hispanics overall were about 4 times as likely as white non-Hispanics not to have completed high school. So very important when you're thinking about health education and ability to understand instructions, if your provider only speaks English. Percentage who speak English less than very well. Non-Hispanic whites 1.6%, Hispanic Latinos about 1 in every 3, and it ranged from a high of nearly 1 out of every 2 Central Americans to a low of 1 out of every 5 Puerto Ricans. So overall, Hispanics were about 20 times as likely to speak English, less than very well compared to non-Hispanic whites. Percentage living below the poverty line, non-Hispanic whites, about one out of every 10 non-Hispanic whites. And then if you look at Hispanic Latinos, about one out of every 4 living below the poverty line. And so once again, there's differences across the various Hispanic subgroups, with a high of 28.3% for Dominicans and a low of 14.9% for South Americans. So in terms of considerations, some of the ethical considerations around the American Community Survey, obviously some of the advantages: it's nationally representative. It includes the major Hispanic subgroups, so it respects the idea of cultural diversity. It's self-reported data, so it's less subject to these issues of misclassification of race and ethnicity. And also, it addresses the issue of respect of autonomy and the right of self-determination to say, this is what I think I am. So it's nice to be able to say, hey, those numbers that you see there, that's what the folks self-reported. Disadvantages are underreporting of self-reported variables perceived as stigmatizing, such as, did you receive certain public health benefits? And if they felt, people may have felt that was a stigmatizing issue, they may have underreported that issue. Also, the possibility of greater non-participation by undocumented persons, even though they're not really asked that question, but that could be a factor. So what about leading causes of death? So on the right-hand side, you can see sort of differences in the 10 leading causes of death for non-Hispanic whites and Hispanics. And you can see that both cancer and heart disease are the first leading cause of death for both Hispanics and non-Hispanics, representing about 2 out of every 5 deaths for Hispanics and non-Hispanics. However, cancer is currently the first leading cause of death in Hispanics, and heart disease is the leading cause of death for non-Hispanic whites. And you're probably wondering, when did that switch occur? Because for a long time, they were the same. And it happened, I believe, in about 2008, there was a flip. And based on some of the findings that we'll share later, we'll try to figure out maybe why some of the reasons were for that. Hispanic death rates for 7 of the 10 leading causes of death were lower than that among non-Hispanic whites. So that was an interesting finding. And there were similar death rates for kidney disease. The only 2 rates that were different included, that were higher, were for diabetes and chronic liver disease and cirrhosis. And we think that those are sort of 2 related causes of death. So in terms of overall, what do we see in terms of mean age-adjusted death rates per 100,000 for Hispanics compared to whites, and at least the 3 Hispanic subgroups that we were able to provide that information for. So for non-Hispanic whites, you can see the overall age-adjusted death rate, 746. For Hispanic Latinos, 566. So it was about 24% lower all-cause mortality rate for Hispanics compared to non-Hispanic whites. However, when you break things down, at least for those 3 Hispanic subgroups, Puerto Ricans, Mexicans, and Cubans, we can see that Puerto Ricans had a similar all-cause mean-adjusted death rate compared to non-Hispanic whites of 703.9. What about looking at the top 2 causes of death? So we talked about cancer and heart disease. And here we can see that in red is heart disease. We can see that it's a lot higher than that for Hispanics. Similarly for cancer in blue, the white versus Hispanic numbers are much higher for whites. And then when you break things down or you disaggregate for the Hispanic subgroups, you can see that for Puerto Ricans, the heart disease rates are very similar, almost identical to that of white non-Hispanics. And the rates of cancer for Puerto Ricans are also higher than other Hispanic subgroups, very close to that of Cubans, but still higher. And so you're probably wondering, well, why is it that Puerto Ricans are a little bit out of whack with the rest of the Hispanics? We'll have to look at that more closely. Let's take a look at, so what are some of the disadvantages and the advantages from the ethical standpoint of the death data? So obviously, it includes a vast majority of all the deaths in the US, so we feel that it should be representative, and it includes a vast array of causes of death, so you can really look at various causes of death and look more closely at that. However, the disadvantages are that we were unable to calculate reliable death rates for all Hispanic subgroups. So this issue of respecting cultural diversity, beneficence, in other words, the idea of maximizing potential benefits and minimizing potential harm. So if you can't break it down, you really don't know if those differences occur or there are differences. So that's an important thing to try and figure out how can we do a better job of breaking it down for the various Hispanic subgroups. Also, ethnicity is subject to misclassification. You know, when you're talking about death certificate data, who's the person who's reporting that, you know, the race, ethnicity, et cetera, of the person who just died? Sometimes it's the family member. Obviously, the person who just died can't tell you what they are. Or sometimes it's the physician who may have been called to the scene and looks at the person and says, well, I think this person's white or Hispanic or whatever, you know. They may not know, so there can be a lot of misclassification. Another thing that we found out was that when we try to break things down specifically for South Americans and Central Americans, in some states, they report those two groups separately, and in other states, they combine the two, so it becomes a Central American, South American category. So if you were to try to look at those, you know, individually, you can't do it. You know, you really can only look at those together as one group, unfortunately, and they're obviously, you know, very different groups. So what about the issue of cigarette smoking? We heard a little bit about that earlier today. And here you can see that overall, white non-Hispanics, about 1 in every 4 smoke. Hispanic Latinos, closer to 1 out of every 10. But once again, when you break things down or disaggregate, you can see that Puerto Ricans, very close to non-Hispanic whites, and actually very close to Cubans, but still the rates of Cubans, although the Cuban rate is similar to that of Puerto Ricans, it's not statistically similar to that of non-Hispanic whites, whereas the rates for Puerto Ricans are statistically similar to that of non-Hispanic whites. So that might be one of the reasons why Puerto Ricans actually have higher cancer rates and higher rates of heart disease because of this issue of elevated rates of smoking. The other thing I wanted to mention is that although Hispanics overall have lower rates of smoking, you know, in terms of the smoking prevalence, we're starting to see that there was an MMWR published last year that looked at smoking among youths, and particularly among looking at middle school kids at a very early age. And we were able to see that Hispanic children actually have higher rates of electronic cigarette smoking and hookah smoking compared to their white non-Hispanic counterparts. So in essence, what we're trying to see is like a reversal of what we originally thought, you know, Hispanics smoke less, but it could be much different in the future. So a lot of the advantages that we've seen Hispanics related to non-smoking may be reversed unless we can put a halt to a lot of the smoking amongst youth. Looking at the prevalence of lack of health insurance, that's another issue. So we can see that non-Hispanic whites, about 15%, Hispanic Latinos, about 41.5%, and once again, there's a range, for the high of Central Americans of 45.8, and a low of 20.7 for Puerto Ricans. So overall, Hispanics about 3 times as likely to report not having health insurance. And then we also looked at prevalences by nativity. And here you can see that no matter what you look at, cancer, heart disease, obesity, cigarette smoking, that US-born Hispanics had higher prevalence of all of those conditions compared to foreign-born Hispanics. So what are some data considerations, ethical considerations? So when we look at the National Health and Nutrition Examination Survey, the one that included both surveys and physical exams, seems like the best of both worlds. So obviously advantages, you're including both of those types of studies. You can use the examination data to validate self-reported data, and it's less subject to reporting bias when considering conditions such as hypertension or obesity. So for example, if you ask someone, has anyone ever told you you have hypertension or high blood pressure? and that person's never seen a doctor or ever, had a blood pressure monitoring cuff attached to their body, they're not going to know. They can tell you no, but that doesn't necessarily mean anything. So in that case, self-report data is not very helpful. But if they have seen a doctor, obviously, and they've been told and they understand the information, then it is helpful. NHANES is representative of the population sampled, the fact that we were able to look at so many different subgroups. It's representative of the population sampled, and it's a large sample size. However, we were only able to look at Hispanics and Mexicans in NHANES, and there were no other Hispanic subgroups that could be described through that study. The National Health Interview Survey advantages, it's representative of the population sampled. Many Hispanic subgroups could be looked at through NHIS. Also, it's a large sample size. It's less subject to reporting bias in relation to race ethnicity. Disadvantages are that there is, because it's an interview, it's a survey, it's subject to reporting bias for the presence of specific conditions dependent on diagnosis by a physician. So in terms of the ethical issues, it brings up the issues of, it respects cultural diversity and autonomy, but at the same time, it may underreport potential health conditions, making it difficult to minimize potential harm, so the issue of beneficence. And then in terms of looking at both NHANES and NHIS, the issue of defining US-born versus foreign-born, that was an issue that we saw that there was actually a difference in how one study defined US-born or foreign-born versus the other study. So in the survey, in the NHIS study, US-born referred to persons born in the 50 states, District of Columbia, or the U.S. territories, and also included children born outside the U.S. to U.S. citizens. And in NHANES, U.S.-born referred to persons born in the 50 states or District of Columbia, but it did not include the other subgroups, such as from, born in the U.S. territories or including children born outside of the U.S. So it makes it difficult to compare data across those two studies. So the issues of valid or standard methods of reporting. Other limitations include sometimes surveillance systems don't even include Hispanics or Latinos, don't include the issue of where you were born or natality. Hispanic ethnic subgroups, much less are even reported, or even if they report US-born, sometimes, what does that mean? Someone who considers themselves Puerto Rican or Chicano or Cuban, you can't get that from the word US-born. Also, the issue of language preference. These are all issues related to beneficence, also respect for cultural diversity and respect for autonomy. So in general, to conclude, some considerations for data collection of Hispanic health and some recommendations would be to improve the methodology of current surveillance systems to allow a collection of key elements in standard fashion, so including place of birth, Hispanic ethnicity, language preference, or other key social determinants of health. And where this is not possible in national surveillance systems, to consider the idea of conducting special studies to supplement surveillance systems to provide more in-depth data that will allow for collection of self-reported data, collection of physical exam data, proper sampling of Hispanic subgroups to provide subgroup-specific data, and also collection of all the data above in the first category that we talked about. And also just wanted to mention that we handed out an article by Coughlin that provides a very detailed discussion. It's a review article and talks specifically about the various ethical constructs in public health. And so I invite you to review that article if you'd like to expand your knowledge of a lot of these terms. And hopefully this particular presentation helped highlight some of those issues. Obviously can't highlight all of them, but I think it was a nice sort of example of both advantages and disadvantages of the current data systems and where there's room for improvement, and also celebrate some of the advantages that we currently see. So.
Thank you so much, Dr. Saenz and Dr. Dominguez. Those were wonderful presentations. So we have a few minutes. We can go till noon, is that correct? Or not? Okay, so what we're going to do, pardon me? We have 5 minutes for questions now? Okay. 5 till 12. Okay, all right. So we have a few minutes for questions. I just want to let people know that we may be getting some questions also via email, and so we'll, go back and forth between people in the room and people in cyberspace. So yes, would you like to go ahead?
Me?
Yes.
Okay, hi. I think in the discussion of ethics, one thing that should be central is historically science has had this indiscriminatory reach toward owning everything it touches. So, for example, when we discuss Latino health outcomes and how every year it just shows to be better and better, if people ask me, well, how can I benefit from that? I say, have a Latina grandmother. Oh, if you can't, then don't think you can just dissect us, objectify us, and grab it. And the reason I bring this up is because my biggest concern in the sciences today, that I think is being gravely overlooked, is the science of the gut microbiome. Because you have people just openly blogging, scientists openly blogging about taking samples from one of the last hunter-gatherer tribes in Tanzania, purifying it in a lab and injecting himself up with it to try to see how he could remedy his Western-born diseases. You have Emory doing a study on 800 African-American women collecting samples of their microbiome. Who's examined the subject agreement? Who's examined that they're protected? Because a lot of us know where the science is going and the power that science can have over the groups that they take. What you can find in this data, it's going to be huge. Has that really been explained to the subject? I mean, this is a really grave issue as far as ethics is concerned in a very burgeoning science now that some people have the eye to try to protect subjects. But it seems like this draw for just learning and owning and grabbing and patenting is overtaking the protection of our subjects, especially with this. I mean, I don't think people would voluntarily give fingerprints, but the common person, how would they know that this, what you have here is your history? It's more identifying of you than your basic fingerprint.
Okay, I'm going to ask you to wrap up just
So this
so
is
we can
one
hear from
thing that
you.
I would love to see the ethics in science start addressing, protection for subjects that are involved in the microbiome type studies. Thank you. Thank you for your presentation.
Do either of you want to comment on that? You have to.
You want to say?
Press. Okay. Yes, many of the issues that you bring to the discussion have been discussed a lot in the context of research ethics. But I think we have to reflect on many of them again, because the lines between research and non-research are more blurred than they used to be. Now, I mean, we have some mechanisms to collect data for public health, but even not for public health. Think about like going over Google searches that now can end up bringing some data for research for whose no consent was obtained. And it's not always the case that consent would be necessary. So the line between what is research with human subjects, what's subject of these protections, and what's not is getting blurred. But additionally, our capacity to obtain information about individuals is also blurred. The key word for research with human subjects is like identifiable data, right? If I deal with you or with your identifiable data, then I'm doing human subjects research. But it turns out that data that in principle counts as not identifiable can be, with certain techniques that we have, be identified. So I think that there's room for analysis there to both distinguish better what counts as research or not, and then decide what appropriate protections there are that are both ethically sound but also feasible.
Just briefly, I would say that not just for the issue of microbiome, but also in general, the area of community participatory research, where you make sure you have a board or some group in the community that you've talked with in the process of developing your protocol, so that they're aware of what the objectives of the study are, and then also trying to make sure that your study staff who's involved in providing consent, getting consent from the patients are representative of the community that you're working with. So I think those sorts of safeguards will reduce the amount of misinformation or lack of information that might result if those sorts of standards are not put into place.
Thank you very much for that question. Do we have any questions from cyberspace? Okay, go ahead, Dr. Barrett.
Just want to thank Carla for your excellent introduction to the field of public health ethics and for plugging our book. I also just want to point out to the audience that the book is an open access book, which means you can download it for free from the internet. And I don't have it on our website yet, but because the book I just found out the book came out like 2 days ago. And so I'll post a link to the book on our website, which is if you go to the CDC website and put in P for public health ethics. If you put in E for ethics, it takes you to the compliance group. So you can find our website, and we also have other training material on public health ethics for people who are interested. And also just wanted to point out that Carla has very generously and hardworking to get the book translated into Spanish. So we thank her for that.
Far out. That's great. Thank you. Drew, do you or Leonard have a copy of the book that you could hold up to show us how it looks?
In my office.
Oh, okay. All right. Yeah, sure.
Carla, you had mentioned something about, all the different kind of questions that have to be asked from an ethics perspective when you're gathering data. And I thought another question that needs to be asked is, from an ethical perspective, what's the purpose? And a lot of times when we hear this disparity data, it's always as though whites are used as some sort of reference group and everyone else is, trying to catch up. But I don't know if we should make that be the goal, the ultimate goal. The ultimate goal should be, and I think I've heard Dr. Warren say this, that the goal should be improving health generally. And one of the things we heard today, both from your talk and the keynote speaker, is the picture is kind of checkered. It's not as though whites are always doing best. And in many cases, other groups are doing better. And so I'm just wondering if one of our goals, and I'm asking a question of whether this is being done, whether we're trying to compile a list of what works. You've pointed out that in certain areas, certain groups are doing better. Is there a real effort to say, what is it that they're doing or how they're living that makes it possible for them to have those improved outcomes? And are we compiling that as a way of improving health in general? And I'm asking that question because it always seems like we're talking about, oh, here's the disparity and this is an injustice. Let's get a particular group up to, the white standard. But shouldn't we be asking that broader question of what is going to improve everyone's health based on what every culture is contributing to good health?
Thank you.
I was just going to say that that's probably one thing that surveillance doesn't do as great a job at, because it can't go into depth. And so I think that's where the importance of special studies comes into play, where you can really drill down and figure out, a lot of those questions that you might have as to, why do Puerto Ricans smoke more, or why are youth smoking more nowadays, and what can we do to reverse that trend so that they can maximize their health potential. So I think probably special studies is what we're talking about.
I entirely agree that the purpose of data collection is key from an ethics perspective. That we can do something doesn't mean it's right. That I can grab some data from you doesn't mean it's right. And so we know that in a number of areas we need more data, but I think that we also should worry about us gathering information, but also, for example, doing testing without doing anything about that. So I think that we have to keep in mind that the reason why it is acceptable to collect data from population in the context of public health in general is because we're going to do something to improve the health of people. And if we cannot put those two together, then we're doing something wrong. So, and I think this is again a discussion that sometimes is at the intersection between research ethics and public health ethics. And I think we have to, I think that we have to approach public health ethics ultimately in a different way. How many times have you been yourself or seen someone in a situation in which you submit something, you have this project and you want to know if it's research or not, and you're told it's not research. You're like, yes, not research, it's one subject. Yes, no IRB review. Woo, no man's land. No. So, but we have put ourselves in that situation, and it's our job now to strengthen public health ethics, to make sure that, yes, while public health is not governed by the same framework of protections for research participants, it's no man's land. There are things that are right and there are things that are wrong, and there's a number of things that might be right or wrong, but we need to start thinking about the work on public health with as if not everything was right. Do we have to do public health ethics work?
Thank you very much. Thank you both for your comments. Did you have anything else you wanted to add? Thank you so much.